Moving on with the next session, I would now like to invite Dr. Jaidev Panchwag on stage. He's a senior consultant and head of the Department of Neurosurgery at Deenanath Mangeshkar Hospital. He is known for his work in the field of microvascular decompression and is a pioneer in starting endoscopic third ventriculostomy in Pune.
I invite our next chairperson, Dr. Kaustubh Dindorkar. He is a consultant neurosurgeon at Deenanath Mangeshkar Hospital. He has a fellowship in neurovascular, skull-based surgery, stereotactic surgery, and spinal instrumentation. Welcome, sir.
I would now like to invite a third chairperson on the stage, Dr. Sanjay Desai. He is a consultant radiologist with Deenanath Mangeshkar Hospital with a keen interest in musculoskeletal imaging, especially MRI of the wrist, ankle, fingers, and foot. Welcome, sirs.
Good morning, everybody. I would like to invite Dr. Kumar Rajmani on dais, and he will be delivering a lecture on ischemic stroke. He's a professor of neurology at Wayne State School of Medicine in Detroit. He's a medical director, comprehensive stroke program there. The chief of neurology, Detroit Receiving Hospital, neurologist and vascular neurologist in Detroit Medical Center. He's a dear friend of all of us, and I extend a very warm welcome to him to Pune and request him to start his lecture.
Thank you very much for that very kind introduction, Chairman. Ladies and gentlemen, good morning. It's really a pleasure to come back here and really enjoy. I've been enjoying the sessions here, meeting old friends and catching up, and I'm really happy to note the progress that academic medicine is making in this hospital. So I want to congratulate you guys on that. My topic for the day is acute ischemic stroke, and without much ado, it's a CME. I have no relevant disclosures, and I will not be discussing any unauthorized treatments. So till 1995, stroke wasn't even considered an emergency. And the advent of thrombolysis in 1995 that was published in the New England Journal in that year, the landmark Sentinel paper, sort of literally dragged the neurologists out of the dark ages and into modern medicine. Till then, stroke was sort of banished to the back benches. Nobody cared about it. But since it was shown that we could give this treatment within that period of time that made a difference to the patient, and that it was safe, things changed quite dramatically. The benefit of thrombolysis in acute stroke was modest at best. It was not a slam dunk, certainly not a magic bullet that everybody wants, but it was shown for the first time that we could give this medicine with safety, and in select patients, you may get very good results. So the improvement that is seen in ischemic stroke is about 30% better than placebo. What it showed is that when patients present with ischemic stroke, with the symptoms, there is an area in the brain which is not fully dead. That is seen in the green there. That is the penumbra. The patient is symptomatic, has a large deficit, but the brain is not fully dead. If you don't treat with, and sometimes in spite of the treatment, this will progress. And what you are trying to do by giving thrombolysis is to prevent the worsening or the completion of the infarct in this penumbra and try to save brain. Although for many years thereafter, in spite of lack of good evidence, many centers were doing thrombectomies. It was only in 2015 that a spate of trials were published. These were randomized trials which looked at patients with relatively large vessel, relatively severe ischemic strokes with large vessel occlusions. And it was shown for the first time that large vessel occlusion strokes respond to endovascular treatment much better than standard of care. So in 2016, 2017, now we were in a situation where we were able to offer this new treatment, which became standard of care. The treatment is this stent on a stick, essentially. It is engages the clot, and quite dramatic results have been seen and reported, on the table as the patient is not even come out of the angio suite. They start moving, they start talking, and quite dramatic results. So these are actual patient clots that are removed. It can be a full sort of red clot, or it can be pieces of a clot, as you see here. You don't have to remove the full thing, but patients still improve quite dramatically. So now we have a situation where we have these treatments available, and they are time-bound treatments, and the challenge is to marry the two and how to provide the treatments in an appropriate time frame to the appropriate patient. So that's the overall treatment effect. An odds ratio of almost 2.5 in improvement of modified Rankin score in these patients with large ischemic strokes. So starting in 1995 with thrombolysis, subsequently 2015 endovascular treatments. Now we have the latest guidelines that have shown how to provide these treatments to the patients. What I would want you to also see is, this is endorsed also by the Academic Emergency Medicine Society. There was a time in the US when the American Academy of Emergency Medicine didn't quite buy into the benefit offered by thrombolysis. They were quite skeptical about the whole thing. And in fact, early on, they were actively canvassing against thrombolysis. They said there would be a bloodbath. There's going to be a lot of accidents, hemorrhages that are going to take place with use of, or rampant use of thrombolysis, which did not pan out. Eventually, they have come on board, and I'm sort of thankful to point out that there is endorsement, at least by some of the academic emergency physicians in the States. The main thing is need for speed, and that's because time is brain. Every minute that there is ischemia, you're losing neurons, millions of neurons. And it's been estimated that about 2 million neurons and their axonal connections are being lost every minute of tissue ischemia. So if you are able to give your treatment, thrombolysis or thrombectomy, even a minute before the earlier, you are able to achieve much better results. And this has borne out in these outcome studies, where they have shown that the earlier treatment has better outcomes even within the 3-hour or 4.5-hour window. Earlier treatment results in better outcomes, better, less mortality, less complications. So not only is the outcome better, there is less complications. So it is imperative that even if your patient may come in, say within half an hour of symptom onset, it doesn't mean that you have 4 hours before you can give the treatment. What it means is you have to give the treatment as quickly as possible to get the best results possible. So based on that, the NINDS, the National Institute of Neurological Disorders and Stroke, have set these targets based on recommendations from the Stroke Association and others. And what they have said is the treatment should be started as soon as possible. The evaluations take place in the emergency room within 10 minutes by the AD physician. There should be a stroke team that should be activated. The CAT scan should be done as quickly as possible. So we have what is called as a stroke protocol CT scan, meaning if there is another patient in the scanner getting a routine test, then that patient gets bumped. If there is no trauma, the next in line is a CAT scan for acute stroke protocol. So that's the importance of that. Time is brain, every minute counts. The CAT scan should be interpreted as we do it, and the TP should be administered within 60 minutes of the patient hitting the door. So that should be our target. So rapid evaluation and treatment. The diagnosis of ischemic stroke is, of course, clinical. A sudden onset of a neurological event, a focal neurologic deficit on a vascular basis. It is important to document what the NIH stroke scale is, which essentially is a score that runs from 0 to 40, and 0 being less, 40 meaning a severe stroke. It's important to document that sequentially. Next important thing is the last known well. When did the symptoms start? If they are not able to tell us when it started, at least do we know when the patient was last known to be well? We send off a whole bunch of blood tests, as I will show you in the next slide, but we really need to only wait for the blood glucose. Even that, all you need is a finger stick. You do not need to wait for anything else for you to commence thrombolysis with TPA, provided there is no other known contraindication. So the lab tests that are required are, as you see, there's a fairly big list, depending upon the patient's situation. But the glucose is the only thing that you want before you start thrombolysis. Suppose there is something that comes in, suppose the INR comes 2.5 afterwards, you can always halt the infusion. That's what the recommendations say. You don't have to stop, or we don't have to hold the thrombolysis for the labs to come back. Unless, of course, there is a history of a liver disease that the patient knows of, or the patient is on warfarin, and we know about that. Otherwise, you don't need to wait. So again, a baseline EKG, a chest X-ray, troponins are all required, but nothing should delay the administration of thrombolysis. What are the absolute contraindications? The list of contraindications has been shrinking over the years. People have been getting more and more confident, and whereas when the initial studies were done, it was very conservative. Now people are becoming more confident. First is the onset time. If it is less than 4.5 hours, you can give TPA. Anything more than 4.5 hours, no. Blood pressure control, active bleeding. If there is active bleeding, then you probably don't want to give TPA. But if there is a history of bleeding a few weeks ago or 10 days ago, you can probably still give TPA. The thinking being you can transfuse blood, but you cannot transfuse brain. That's the thinking. Then there are a whole bunch of relative contraindications. Now, rapidly improving symptoms. Previously, we thought the patient's going to get better. We know now that even if they are left with a minor deficit, it seems to be disabling to a significant number of patients. Pregnancy, they are given TPA in pregnancy. You don't want your mother of the baby to be paralyzed and not able to take care of the baby. Seizure at the onset. So these were sort of relative contraindications where previously we thought it was not required, but now we know that it's helpful, and you can have a discussion with the patient and the patient's family about thrombolysis. So we do the CAT scan, and why do we do the CAT scan? We know it doesn't show the acute infarct. What you want is the patient's CAT scan to be absolutely clean, normal. sometimes you will find a hyperintensity in the region of the middle cerebral artery, which is the hyperdense MCA sign, which suggests that there is a clot in the vessel. And if that corresponds to the side of the patient's symptoms, then it sort of has good predictive value. Sometimes you may find calcifications on both sides, and you've got to be a little careful not to overread that. What you don't want to see is a big hemorrhage. A big hemorrhage would be a contraindication to give thrombolysis. You should look for subarachnoid hemorrhage in appropriate patients. And what you also don't want to see is these early ischemic changes. There is this loss of gray-white distinction. You're seeing mass effect here, pressing on the frontal horns, midline shift, and in fact, this is a big MCA. In fact, this patient is going for, in fact, a craniectomy the next day. What about, so that's thrombolysis. What about endovascular treatments? Since the last 2 years has become standard of care, anybody more than 18 years is what the standard recommendation is. Even although our thrombectomy, our endovascular specialists have done it even in 8-year-olds and 10-year-olds, rarely. There should be a reasonable severity of the stroke, NIH stroke scale 6 or more, which then suggests there may be a good chance of a large vessel occlusion. The symptoms should be less than 6 hours, and a good CAT scan based on the aspect score. So if you are eligible for IV-TPA based on the guidelines with a clinical diagnosis of stroke, when the deficit doesn't remit spontaneously, but sometimes patients may have relatively low NIH stroke scale and have, say, a isolated aphasia, which is a life-threatening, not life-threatening, but life-altering symptom. You can offer thrombolysis to these patients. Isolated hemianopia can be quite devastating. So even if the NIH stroke scale is low, you might want to offer TPA to these patients. How do you determine evidence of large vessel occlusion and eligibility for endovascular treatments? What we do is look for a penumbra based on CT perfusion images where there is slow flow, that is increasing the mean transit time of the flow of contrast through the cerebrum in that part of the brain, associated with a slightly increased or normal cerebral blood volume and reduced cerebral blood flow. So increased mean transit time with preserved or increased cerebral blood volume. That is what is suggestive of a penumbra. A CT angiogram will show an occlusion, large vessel occlusion. So this is a clot in the M1, and which can theoretically be removed. In the last few months, we have been grappling with the issue of wake-up strokes. Patients who wake up with a stroke, we don't know the answer of the symptoms. It's thought to be the last known well when they went to bed, whatever time they went to bed. So they are outside the TPA window. But if you can show that they have a demonstrable penumbra on CT perfusion and a large vessel occlusion, so even though they are 8, 10, up to 24 hours after last known well, these patients do well. So that's the wake-up strokes. The next thing I want to stress is, and this has been stressed in the guidelines as well, is stroke centers should have, quality assurance, and you should have protocols set and ready to be able to do these treatments with ease and with smoothness. You should have quality improvement committees, and you should review your data ever so often and try to improve the processes. So I think I can skip that. So slide at the end, if a patient presents with an ischemic stroke, so you review the TPA eligibility checklist. If there are no contraindications, and if the NIH stroke scale is relatively low, 6 or low, the onset is within 4.5 hours, you can administer TPA per protocol. If the NIH stroke scale is 6 or more, that means it's a more severe stroke, and the patient is presented within 4.5 hours, you can offer IV TPA and consider this patient for endovascular treatments, because they have a very high chance of large vessel occlusions. And if there is a large vessel occlusion, then the chances of thrombolysis by itself relieving the symptoms is much less, as the studies have shown. If it is more than 4.5 hours, obviously you cannot give TPA, but they can be evaluated for endovascular treatments. Regardless, if they give TPA or if they get TPA and endovascular treatments, the patient has to be monitored very closely for at least 24 hours in the ICU. And then same for wake-up strokes. Last known well is unknown, and we look for the penumbra on CT perfusion. That means there is viable brain, and if there is a large vessel occlusion, that is demonstrable. When we say large vessel, we talk about the middle cerebral artery, the basilar artery, and the tip of the internal carotid artery, the ICAT. And if this is present, then they are good candidates for thrombectomy. What is extremely important is public education. We may have all these treatments, we may have all the processes ready, but if the patient doesn't know this and it's not well known, then we won't be successful in giving these treatments. So some sort of public education program is extremely important. I think that's any questions? I have two very simple cases, right? Yeah.
First, we'll do MCQs and then take a question, or?
Yeah. Anyway, I think the question was, is there any role for MRI in acute ischemic stroke? Yes, there is, depending upon your hospital. If you are able to get the MRI scan very quickly and efficiently without losing time, most certainly. Every hospital should have its own protocols ready. In our hospital, we deal with CT scans and CT angiogram, and it works very well for us. And I know other centers do only MRI scans. So yes, there is a role, and in fact, in the guidelines, it's mentioned, regardless of what type of imaging is used, provided you use some form of imaging, it's probably all right. Okay. All right, so let's go to the very simple question. A 68-year-old man is seen in the emergency room with acute onset of left-sided weakness, left hemi-neglect, beginning 1 hour ago. His blood pressure is 154/90. The NIH stroke scale is 9. Which of the following medications, if taken earlier that morning, would represent an exclusion to IV thrombolysis? Okay. Very good. The correct answer, I think majority of you have got the correct answer. That's dabigatran. Antithrombotic, antiplatelet agents are not a contraindication for TPA. Patients can have aspirin on board. They can have clopidogrel on board. They can have dual antiplatelets on board. But it's the lisinopril shouldn't matter. Warfarin, if the INR is 1.7 or more, then it's a contraindication. The INR is 1.5, so it's probably okay. But dabigatran is a newer oral anticoagulant agent, and if they have taken it within the last 24 to 48 hours, is a contraindication. Good. Next one. 65-year-old is seen in the emergency room with acute onset of aphasia and right side weakness starting 1 hour ago. His blood pressure is 150/73. His heart rate is 90 beats and irregularly irregular. The NIH stroke scale is 19 with points for left gaze preference, right-sided weakness, right sensory loss, and global aphasia. So it's a very severe left MCA territory ischemic stroke. Head CT shows hyperdense left MCA sign, suggesting there's possibly a clot. Which of the following is the most appropriate next step in the management? D. Awesome. I think the majority of you again have got that right. D is the correct answer. Obviously, there's no role for decompression just yet. Sometimes the treatment fails. They may need it eventually, but that is not the first treatment. IV heparin has no known role in acute ischemic stroke. IV TPA alone may not be adequate because of the severity of the stroke and the fact that there is a big clot, and hence the correct answer is IV TPA followed by evaluation for intervention, endovascular treatment. Okay, thank you.